So we'll start with management of Budd Chiari syndrome. And just a brief recap on the last class, that first, when we were doing the imaging of Budd Chiari syndrome, what were we looking at? Number one, we were looking at whether it is an acute or a chronic disease. Second, we were looking at what is the level of obstruction. So whether the hepatic veins are involved, IVC are involved, or both are involved, because that will change the management completely. So one is acute or chronic, then the level of obstruction, then the length of obstruction, whether it is a short segment narrowing or the long segment narrowing. So our whole imaging is dependent on answering these three questions, correct? Now, normal hepatic inflow is through the portal vein. Hepatic arteries only have around 20% of inflow, so main inflow is via portal vein. So we want that portal vein should also be patent. And the outflow is via the three hepatic veins and the IVC. Now, what happens in chronic Budd Chiari syndrome, that either one or all hepatic veins will get obstructed. Now, even if you have one patent hepatic vein, one good patent hepatic vein, the liver will not get congested. The liver patient will not have Budd Chiari syndrome symptoms. You need only one hepatic vein and a patent IVC to adequately drain the liver. But if all the three hepatic veins are either stenosed or completely occluded, then the liver will get congested and then you need to treat that patient. So Tanvi is asking, sir, why hepatic artery is enlarged? So whenever there is cirrhosis, and you will see if it has one of the findings in cirrhosis, in fact, that cirrhosis raises the portal pressure. So the blood flowing through the liver into the liver through the portal vein reduces because there is increased antegrade pressure by the liver parenchyma. So to overcome that resistance, hepatic artery takes over the portal venous supply, and that gradually increases in caliber. So you might have seen that the flow in portal vein becomes hepatofugal in cirrhosis. It is away from the liver. So how will liver get the blood supply? That is through the dilated or enlarged hepatic vein or hepatic artery. So our three questions were acute, chronic, hepatic veins, IVC, or length of stenosis. Now these three things will determine our management. So we divide it into acute, subacute, chronic, and a frank cirrhosis. And in acute presentation, the only goal is anticoagulation and thrombolysis. In acute Budd Chiari syndrome, we want to restore the normal physiological flow through the hepatic veins and IVC. So now anticoagulation, the hepatologist or the gastroenterologist will give IV. Thrombolysis can either be systemic or a catheter-directed thrombolysis. Now, systemic thrombolysis, the clinician gives the TPA or the streptokinase, but most commonly in practice, anticoagulation is given IV, and thrombolysis is usually a directed thrombolysis, catheter-directed thrombolysis. So you cannulate the thrombosed hepatic veins or the thrombosed IVC, and you inject small amount of TPA, like streptok or like tenecteplase, alteplase, you inject it into the hepatic veins through that catheter, and you keep that catheter within the hepatic veins for 24 hours. This is CDT or catheter-directed thrombolysis. Now, this you'll also see in stroke, you'll also see in pulmonary embolism, you'll also see in DVT, acute DVTs, as well as in acute limb ischemia. So catheter-directed thrombolysis, the concept is simple. You go into the affected artery or the affected vein in this case, give small amount of TPA, and the remaining amount you give it as a slow infusion via thrombolysis catheter. In a chronic presentation, now whenever there is a subacute or a chronic presentation, then you have to decide that what do I want to treat. Now, wherever there is blockage of, at whichever level there is blockage of outflow. So let's say IVC is getting stenosed, you open up the IVC. If the hepatic veins are getting stenosed, you open up the hepatic veins. Whatever length, whichever part of the outflow is obstructed, you open it. Now, before opening it, you decide whether it is a long segment or a short segment occlusion. So if it's a short segment occlusion, our job is simple. We cross the narrowing, inflate a balloon, do an angioplasty. And if that angioplasty is not sufficient, we put in a stent. Whereas if it is a long segment occlusion means that the native hepatic veins are not healthy. So you cannot put in a stent, because if you put in a stent in the hepatic veins, the rest of the hepatic vein is abnormal. It will not drain. So in a long segment occlusion of a chronic or a subacute presentation, our only choice left is a TIPS. Okay. Now, let's come to a scenario in which there is frank cirrhosis. So, liver is nodular, shrunken, there is caudate hypertrophy, patient has ascites, he might have acute variceal bleed. So, frank cirrhosis with decompensation. Now, in this case, our options are limited to either transplant or TIPS. Now, even in chronic frank cirrhotic patients who have decompensated, TIPS is usually the treatment that is given, because liver transplant are done A in very limited centers, plus B, there is paucity of grafts in the country. So TIPS is also done in frank cirrhosis. So I hope this brief overview is done. Acute presentation, thrombolysis or anticoagulation, or a catheter-directed thrombolysis. Subacute or chronic presentation will see the length of the stenosis. So if it's a short segment stenosis, we might as well do an angioplasty or stenting, but it's a long segment stenosis. We can't do an angioplasty because there is no healthy vein left. Then our only option is to do a TIPS. Now, goals of the treatment is treatment of the underlying disease. So if the patient has a procoagulant state, a myeloproliferative disease, uh, you treat that. Second is correcting of hepatic venous outflow obstruction. Now this second point can either be done by angioplasty. Now when do we do an angioplasty? If the native hepatic vein is normal. Now in the subsequent slides, when I'll show you the cases of hepatic venous angioplasty and stenting, I'll tell you there that the native hepatic veins were normal. That is why we could do a angioplasty. So if the outflow is at the, if outflow obstruction is at the level of IVC, you open up the IVC. If the outflow obstruction is at the level of hepatic veins, you open up the hepatic veins. As simple as that. And third goal of treatment is to treat the portal hypertension complications. So treatment of underlying disease, if it's a myeloproliferative disorder, you do appropriate chemotherapy. Polycythemia vera, you do phlebotomy or hydroxia. PNH, you give eculizumab. Bechet, Sjogren's or SLE, you give anti-inflammatory and steroids, and so on and so forth. Basically, treatment of the underlying disease. Now, treatment of the hepatic venous outflow obstruction. Second goal is correcting the hepatic venous outflow obstruction. Now, to do this, step one is to give anticoagulation, usually a low molecular weight heparin or vitamin K antagonists are given. They help in recanalization and prevent thrombosis and progression of disease. Second is to do a percutaneous angioplasty to restore hepatic outflow obstruction. So let's say an IVC obstructed, you open up the IVC. Hepatic veins are obstructed, you open up the hepatic veins. For liver congestion to happen, all three hepatic veins should be blocked. Even if one hepatic vein is patent, liver will not get congested. Okay, so your goal of treatment is to open only one hepatic vein. That is why you will see that, okay, if all the three hepatic veins are stenosed, you still do a stenting or angioplasty of only one hepatic vein, because that is sufficient to drain the liver. Now, third aim is to control portal hypertension decompensation, and for that a TIPS is required. And step 4, if patient is in fulminant hepatic failure, then the only option left with us is to do a liver transplant. So even HVOTO cases, hepatic venous outflow tract obstruction cases, also can undergo fulminant hepatic failure if there is acute thrombosis of all the three hepatic veins, as well as, thrombosis of the portal vein. So I remember recently, a month back, there was a case admitted in our hospital in which all the three hepatic veins were acutely thrombosed, as well as portal vein was acutely thrombosed. And so in that case, the patient had a fulminant hepatic failure. We did a hepatic venous angioplasty and thrombolysis, but still the patient could not be saved. So fulminant hepatic failure is a very, very high lethal complication of BCS. Now, the third goal of treatment is portal hypertension complication treatment. So if it's a variceal bleeding, you do an endoscopic band ligation, sclerotherapy, and give non-selective beta blockers like propranolol. So you will frequently see in OPD card of a patient that they are on carvedilol, which is a non-selective beta blocker, and patient has gone multiple sessions of upper GI endoscopy with variceal ligation. If you are planning to do a TIPS and the patient is decompensated with an acute variceal bleed, Through the tip stent also, you can cannulate the left gastric vein and embolize the antegrade varices as well. That is known as antegrade variceal embolization through the tip stent. Now, if the second complication is encephalopathy, you treat encephalopathy by medical management. So, anti-coma measures, what comes in anti-coma measures? So, lactulose and rifaximin antibiotic. If the patient has ascites, the patient is put on a low sodium diet, diuretics are given, therapeutic paracentesis is done, and an albumin infusion is started. So this portal hypertension complication is mostly managed by the medical team. Our main is our main aim is to correct the hepatic venous outflow obstruction. So medical treatment is in the form of anticoagulation like low molecular weight heparin, vitamin K antagonist, and direct oral acting anticoagulants. And these patients usually require long-term anticoagulation as most have a prothrombotic disorder. Now, systemic thrombolytic therapy can be given in the form of streptokinase or urokinase or a recombinant TPA. So when we have decided to treat a hepatic vein outflow tract obstruction, the first step is to do a venography. So venography is usually done via transjugular route. Okay, we puncture the right IJV, go through the right IJV into the heart, the suprahepatic IVC, and try to cannulate the hepatic veins. So this is the gold standard test to assess the IVC and the hepatic venous circulation. The preliminary procedure, it is a preliminary procedure to any radiological intervention. So even if you want to give a catheter directed thrombolysis, you have to cannulate the hepatic veins, do a venography and see how much of the hepatic veins are filling. If you want to do mechanical thrombectomy through a balloon or a catheter, again you'll have to cannulize the hepatic veins. So venography is a preliminary procedure to all radiological interventions. It can be performed either a jugular, femoral, or a brachial route, and it accurately demonstrates the site and extent of thrombosis or stenosis. And through that catheter that you have put, you can also measure the pressure gradient across the stricture. So that also tells you that yes, there is an obstruction at the level of hepatic venous outflow. That is why you're getting a gradient and you need to treat it. Correct? Now, what can be the findings on venography? So let's say the obstruction is at the level of IVC. So IVC can either be completely occluded